The background on this orthokeratology case is a patient who was fit with lenses a few years ago and was out of lenses for a little while and is getting back into lenses now. During that time, the patient's myopia had increased a little bit, so we're trying to design new lenses and incorporate some additional correction. And if we look at the posterior topographies with the new lenses, we can see that the lenses are riding quite low. And usually this happens when a lens is too tight, when there's too much sagittal depth in the lens, or it can also happen if the lens is too small. So I'm going to bring up lenses here, and there were a few lens designs incorporated. I believe this one where the blending is turned off is the one that the patient is using right now. This is the new set. And so what I'd recommend on these lenses is probably to turn the blending back on and realign the periphery of the lens. Maybe decrease the edge lift a little bit, and then we can decrease also the apical clearance, get this lens to be overall a little bit flatter, and that should get the lens to center up a little bit more nicely. So turning that off. And then anywhere from 2 to 3 microns of central clearance. Maybe we'll do that other one. Okay. The other thing also is if the patient does have a diopter more myopia than before, is probably want to increase the power in the lens a little bit. Right now, it's fairly similar to the original lens that was fit about 3 years ago. And so if our original power was 141, then we probably want our new power to be about 241. Anytime I change the power, even though we're in 100% mode, I do go into 25 and just check the other meridians. We can make this a little bit more uniform. Also, the patient does have fairly large corneas. I measured at about 12 millimeters, so I would go all the way up to an 11.8 on this lens. If the lens is too small, that can also cause it to decenter. Anytime you change the diameter, you have to reset your thicknesses. So now we've got a larger lens with a little bit edge lift. The blending has been turned back on, unchecked to turn on. Decreased the sagittal depth of the lens a little bit, and see if we can get this to center up a little bit better on the patient's eye. I think the reduction in the best corrected acuity is probably just because the patient is looking right through some irregular astigmatism due to the inferior decentration of the lens. So even with the OR in place, the vision wasn't much better than 20/40. If we can get this lens to ride a little bit higher, we should get a more homogeneous treatment, and the patient should get slightly better vision. So I would do very similar changes to the left eye, maybe turn the blending back on, reduce the edge lift, and increase diameter, and then drop the apical clearance down a little bit. So I would give that a try. Hope it works well, and good luck with your patient.